afternoon and welcome to this public meeting of the Standing Committee on Social Development. My name is Cheryl Yakalaya. I am the MLA for Techo and Deputy Chair of the Standing Committee on Social Development. I will now ask members in the room and online to introduce themselves for the record. Ms. Morgan.
Thank you. Good afternoon. I'm Shauna Morgan, the MLA for Yellowknife North.
Online.
Hello, I'm Kieran Testart. I am the member for Range Lake here in Yellowknife, and unfortunately I can't be there in person. I have the flu.
Hi, Madam Chair. Thank you, Committee. Robert Hawkins, I'm the MLA for Yellowknife Centre, and as always, I'm happy to be here. Thank you.
Mr. Narasu, can you hear us? Okay, thank you, members. And today we'll receive a briefing on healthcare sustainability accountability from Lisa Little Consulting. This briefing is part of the community committee's study on healthcare and sustainability and accountability. Please note this meeting is being live streamed to the Assembly social media channels. I would like to remind all members and witnesses to direct all questions and comments to myself as chair and to wait to be recognized before speaking to help us have a smooth meeting. I will now pass the floor over to Lisa Little. Please proceed with your remarks.
Thank you very kindly, Madam Chair, and to the members of the Standing Committee on Social Development for your invitation to present to you today on this topic. I want to acknowledge that I'm speaking today to you from the unceded territory of the Anishinaabe and Algonquin Nation. My name is Lisa Little. I am spent 35 years as a registered nurse in Canada in clinical, management, education, policy, and leadership positions. I've spent 10 years at the Canadian Nurses Association leading their work on nursing and health workforce or health human resources, as well as many other health system challenges around accessibility, affordability, and sustainability. I've been working as a consultant in my paid day job and for the last 5 years for a Northern Health Territory. And I currently serve as the first vice president of the International Council of Nurses, which has 130 National Nursing Association members around the world, representing over 28 million nurses. So I wear a couple of hats today in my comments to you. I want to begin by saying that the challenges that the Northwest Territory is experiencing are not unique as it relates to nursing and healthcare systems. Half of the world's population does not have access to universal health care. The world's population is aging, and non-communicable diseases or chronic diseases account for over 70% of deaths worldwide. And unfortunately, the world is experiencing a global nursing shortage, estimated to be anywhere from 10 to 30 million nurses. Without a health workforce, there is no health system or health care. Nurses comprise 70% of the health workforce in Canada. Investing in nursing is key to ensuring health system sustainability and improving the quality of care, life, and well-being of residents and healthcare staff in the territory. I want to direct you to ICN's latest International Nursing Day report this year, Our Nurses, Our Future, the Economic Power of Care, and it's available on our website. In the report, health economists reveal the true value of nursing to societies, how elevating the nursing profession can catalyze transformative improvements in healthcare delivery, economic development, and societal well-being. What they have told us is what we already knew, that investing in nursing jobs, education, and leadership results in an excellent return on investment. That means every dollar spent pays for itself many times over. Contrary to belief, nursing is not a cost to the health system, but is rather an investment in the health of populations and health systems. And ICN believes that investment in nursing jobs should be prioritized in primary care and embracing a primary healthcare approach. The key to health system sustainability is to invest in the principles of primary healthcare as first articulated in Alma Ata in 1978, including illness prevention and health promotion, team-based care, the appropriate use of technology, and intersectoral collaboration. This means investing in more care outside of hospitals that is integrated across settings and providers, is patient-focused, and with special consideration for reaching the underserved populations and communities. More nurse practitioners and nurse-led models of care can transform the health system and improve access to care and improve the health of the population. We have decades of research to show this. And we definitely know that this is a reality in the territories such as yours, where nurses provide the bulk of healthcare. Prioritizing investments to enable healthcare workers to work to their full or optimal scope of practice, including advanced practice nurses and nurse-led models of care, improves health system efficiency and effectiveness. According to the OECD, the OECD, 76% of doctors and 79% of nurses report being overskilled for the roles they were performing in their day-to-day work. This means supporting nurses with more administrative support and unregulated providers to assist with non-nursing tasks. Research shows that 30% of what nurses are doing does not require nursing education, like paperwork, faxing, stocking shelves, finding equipment. Given the cost and length of educational programs for doctors and nurses, this represents a huge waste in human capital. This also means connecting nurses in territory with nurse specialists outside the territory through means such as telehealth, which we all know ramped up since COVID. Clinical nurse specialists in the area of wound care, gerontology, mental health and addictions, and women's health. These are just a few examples, but they can be supporting direct care through nurse-to-nurse consultations, but also supporting the ongoing continuing education of nurses in the Northwest Territories. ICN has also released a Charter for Change, which presents 10 vital policy actions that governments and employers must take to create and sustain healthcare systems that are safe, affordable, accessible, and responsive, and to shift the paradigm and allow nurses to be visible, valued, and vital for the health of our countries, and to nurse the world and profession back to health. I encourage you to read it. I would just like to highlight a few of those policy actions. We know that nurse burnout is a common phenomenon post-COVID. With rates of greater than 80% in Canada, it requires immediate attention. ICN urges governments to urgently address and improve support for nurses' health and well-being by ensuring safe and healthy working conditions and respecting their rights, including zero tolerance for violence in the workplace and creating psychologically safe work environments. And have work environments that support the health of nurses through stress-relieving activities and fitness equipment available. That's really important in some rural and remote communities. And most importantly, put in place safe staffing levels to meet population health needs, never allowing nurses to work alone. Investing in nursing also means supporting them to excel at their job. ICN urges employers to uphold positive practice environments that listen to nurses and provide them with the resources they need to do their job safely, effectively, and efficiently. Invite nurses to the decision-making tables. They have solutions to many of the health system's challenges and problems. They experience it day in and day out. As you know, they're there 24/7 with clients or patients. For too long, their voices have been absent. I urge you to consider funding recognition programs and professional development activities across career trajectories. Nurses and all healthcare professionals need enhanced digital literacy to help transform healthcare into the digital age. The appropriate use of healthcare technology is key to its sustainability and supporting accountability with an abundance of digital health and health system data. I urge you to also support flexible models of employment and scheduling. Our colleagues in Australia have shown us how job shares and fly-in and fly-out models can serve rural and remote settings. Ultimately, nurses want to feel valued and respected like everyone else in their job. Ask them what they want. Conduct surveys with your nurses, focus groups with your nurses, and ask them what is meaningful to them. I cannot understate the importance of nurse retention, and I urge you to review the Nurse Retention Toolkit that was released last year by Health Canada under the leadership of the Chief Nursing Officer. It has practical, evidence-based examples from across the country. The best nurse recruitment strategy is an effective retention strategy. Word gets around and everyone knows where the best places are to work. One aspect of recruitment and retention that I think you may find helpful to your rural and remote setting is the work of an Australian researcher, Kathy Cosgrove, who speaks to the importance of professional, social, and personal integration into the health system for health workers. This requires creating a seamless orientation and professional onboarding experience that helps new healthcare professionals settle in quickly and comfortably within your organization in terms of their roles and responsibilities. It also means ensuring that staff feel supported, valued, and motivated from day one, which lays the foundation for long-term retention. It also means settling and connecting new employees and their families into local community events, schools, churches, etc. And at the individual level, it means really understanding what motivates your healthcare workers. What do they personally seek out of their life in the Northwest Territories if they've come from outside the territory? And provide them with the information and the opportunities to make that a reality. Those three components together, the professional integration, the social integration, and the personal integration, really need to come together to support nurses and other healthcare workers if you're going to retain them in the long term. I did a piece of work years ago with the Canadian Medical Association, and we went out to some rural communities in Ontario. I know it's not the same as Northwest Territories, and we asked them what worked in keeping their healthcare professionals in their community and hiring them and getting them to stay. And they told me it was two things. It was M&M, mortgage and marriage. Find them a partner and get them to buy a house and tie it into a mortgage, and they'll never leave your community. Thought that was quite interesting. The other principle underlying a recruitment and retention strategy is for it to resonate with 5 generations we now have working in our healthcare systems. What attracts 20-year-olds is not the same as what attracts 40-year-olds, and the same applies for retention. One thing we notice with the younger generation is that they're not necessarily looking for a 20 or 30-year career with one employer like my generation did. They will most likely work for you for a few years, gain the skills they want, explore your wonderful landscape, and move on. And we have to accept that and build that into our workforce planning. And key to it all is developing nursing and broader health workforce plans that take into consideration community needs, primary health care, including a shift to greater illness prevention and health promotion, emerging models of care such as telehealth, team-based care, and enhanced technology, all integrated across the continuum of care. ICN urges you and all governments around the world to create workforce self-sufficiency with you and your government partners across Canada to follow the WHO Global Code of Practice on the international recruitment of healthcare professionals, not relying on the recruitment of nurses from other countries who are also experiencing a nursing shortage, often in worse positions than those of us in high-income countries like Canada. Health system accountability will continue to strengthen as you embrace evidence-based healthcare and decision-making, and use the abundance of digital data to annually or quarterly report on key indicators for the health system goals you have set for your territory. Publicly available data brings accountability. It also, for not only the public, but for the workers themselves. And I would encourage you to include nursing specific data to show the impact of nursing care. For too long, electronic health records have only captured medical data per se and tests and results. But what about the impact of the nursing care that you're providing? To know whether you're making a good investment, you have to understand what the impact of care is and what the impact is on many things, whether it's the health of the population, reducing costs in your system, etc. And so you need to find ways to start capturing the work that nurses do in electronic health records. Investment in those electronic data systems is key. As Peter Drucker has stated, you can't manage what you can't measure. And so we can't expect accountability if we don't manage the system to achieve that. And we can't manage the system if we don't have the data to understand how the system's doing. Thank you for the opportunity to share some thoughts with you today, and I would be happy to answer any questions.
Thank you, Ms. Lill, for your presentation. I will now ask the members if they have any questions. I can't see Kieran if he's got his thing on. Ms. Morgan?
Thank you very much, Madam Chair. And thank you so much, Ms. Little, for sharing your insights with us. I think there's a lot of things in there that really resonate with our situation here in the Northwest Territories. A couple questions I have, terms or concepts that I'm not as familiar with that I wondered if you could explain a bit better. You talked about the importance of nurse-led models of care. Can you explain what that would look like?
So some of those are nurse practitioners, for example, where they're providing primary care to communities. And I know you have some of this already, but it's really looking at as well, maybe wound care, right? You don't necessarily need a physician. So maybe there's wound care clinics that are managed by nurses who have specialization in wound care that clients come in and are be seen. Where you don't need a physician order for something, where the nurse is working at her optimal or top scope according to what she's educated and registered and legislated to do, that they can manage many of those patients on their own in terms of wound care. Maybe it's other areas around, well baby visits, right? Nurses doing those on their own. Maybe there's communities where you need outreach for people who are homeless and on the streets, right? So we've seen models where there's mobile vans or buses that go out or walk the streets to meet those clients where they are. And those are led by nurses, again, who, make relationships with those clients, understand what their health needs are. Maybe they need a vaccine shot. Maybe they need, some wound care. Maybe they need some diabetic teaching. It doesn't require a physician, but it makes a huge impact because they understand greatly the social determinants of health, and they look at that client as a whole person and try to address their needs. So I think thinking about, because we all know physicians are limited as well, and they bring a certain expertise that we want to use them for. So we say the same of nurses, of registered nurses or nurse practitioners or registered psychiatric nurses, using them for their expertise of what they're educated to at the top. There are opportunities where they can provide this care, sort of in an autonomous manner.
Thank you. Thank you, Ms. Lill. Ms. Morgan?
Yeah, thank you for that. And I do think we actually, in many of our communities, that ends up being what we already do, but perhaps we don't embrace it enough in terms of recognizing the full scope of what nurses can do and allowing them to really take the lead. Okay, another question I had. So you mentioned the importance of, in terms of retention, flexible models of employment and scheduling. And we hear this a lot from frontline healthcare professionals, including nurses, that people want to have sort of more part-time arrangements or more flexible scheduling that would allow them to have more realistic schedules to be able to care for family or whatever it is. we're also told sometimes that, oh, well, that's really very difficult in a smallish healthcare system like ours. We would love to be able to offer all kinds of people part-time work, but in a small system, that's just too hard. So we can't do that as much as we would like. Do you have any thoughts on whether those flexible models of scheduling part-time employment can work well in a relatively small system where you don't have, unlimited numbers of staff to sort of toggle around and fit into the slots? Have you seen examples of where that has worked well in small systems? Thank you.
You, Ms. Morgan, Ms. Little?
Yes, thank you for the question. So I'm not going to speak out of turn, but it is public. The government of Nunavut in the last year negotiated in their collective agreement for an MOU that allowed for new type of job share positions. So it embraces this Australian model of fly in and fly out. So the nurses would share one position, and so they determine amongst themselves what the length of their stay would be in. So maybe it's 2 months at a time. So one comes in for 2 months, and then the one is out in the south, perhaps working, or wherever they might be, or not working, and then they would switch. And every 2 months they switch in and out. They share one accommodation. Obviously, all the benefits and salaries are prorated. And so that's an example that's actually happening now in the Yukon. You can see there are positions posted, there are positions filled, in the Yukon, the Nunavut, for job share positions. And this has been very popular. Another aspect is that, you can look at those job shares and make them a little bit longer. Maybe people want to come in for 4 months. And so again, you can work with those, and it's not for every position. I'm not saying that, but there are some where maybe it is difficult to recruit, or a certain type of position, like your community health nurse or a public health nurse, that you allow that to happen. Other models are where you have a lot of casuals, maybe that do come in and do stints of work. Having software that allows them to self-schedule. So you put out what your needs are, and they plug in what their availability is on a first come, first served basis. It can also allow them to plan out for a year what their requirements are, or what their travel plans would be to come in and work for you over the course of a year. I think it's quite possible. I mean, in Australia, they've done it in very small communities. That was how they got people, because no one wanted to. I shouldn't say no one wanted to. It's not as enticing to come work in a very, very tiny community where, there's not resources for your family and schools and all these other things. That maybe the fly in, fly out model works very well. And so I can say that it is happening in Nunavut right now.
Ms. Morgan, do you have another follow-up? No? Any other members have any questions? Mr. Testar?
Yes, thank you, Madam Chair. So we hear often that, not only, we know that the Northwest Territories is in a healthcare crisis, and that's particular around staffing, especially right now. We also hear this is a problem in Canada. Often our health minister will say, this is a national problem, and we know it's also an international problem. So how would you assess the Canadian condition as it relates to the healthcare crisis, and which jurisdiction is being most proactive in resolving it? Thank you.
Yeah, so Canada is short hundreds of thousands of nurses. We're no different than, and relative to size of our country and to other countries, obviously, African countries have worse shortages than we do, let's put it that way. And other high-income countries have significant shortages as well. Within the country, within Canada, I'm not sure I could comment on which ones are doing better or worse. I think the ones who are doing better have a plan, have a detailed, health workforce strategy plan that, again, embraces some of those elements of what's effective recruitment, some of the things I talked about, really focused on retention and really focused on valuing people and what they bring. I think some of the best success is what you see it as an employer level, actually, as opposed to a provincial or territorial level, where I've spoken with employers who have, really embraced and taken up addressing the burnout of nurses, their mental health and providing supports for them, dealing with them as an individual and not, a number, almost a case management approach to their staff, providing them with professional development opportunities, providing them with opportunities for decision making. And they tell me they have almost 0% vacancy rates. Those that do that, those that invest in their workforce and make them a priority, and have created positions like downtown Toronto for the person that's now in charge of the health of their workforce, the health workforce. So I think there are pockets that are doing things well, but I think it's deliberate. I think it encompasses a strategy with tactics and a plan that's detailed, that has money assigned to it and accountability assigned to it, and you're tracking your indicators. That those are the people that are having more success than others. I think there are some who are taking shortcuts and not doing as well. Ontario obviously that's where I am, isn't a big conundrum. I mean, it's not going so well here for the most part. There are some pockets, though, of great things that are happening. But I think it's at an individual employer level. We're a little bit structured differently than in some of the other provinces and territories. But I think the other piece that this for me speaks to is, and we've talked this for years since I was at the Canadian Nurses Association, the need for you to really partner with other governments across the country in a pan-Canadian strategy. The territory has education programs for healthcare workers, but not for all the types of healthcare workers. And often those programs only put out a few individuals per year, nowhere near enough to meet your needs of what your vacancies are and your everyone has natural turnover. That's going to happen. And so really starting to say to provinces in the South, or as a collective, at your FPT tables, to say, we need you as a government. Let's say you want to partner with Alberta to say, we need you to produce more nurses in excess of what you think you need, because we need some. Could we buy seats at your school? I mean, we've got places now providing free tuition for nursing students with a return of service program. You could say, we're going to put you in, and we're going to take nurses in Alberta and say, if you go to school through the education program in Alberta and the government, partners with you to do that, you pay for the seat and you give us a return of service after that, we'll give you, X number of dollars, and we'll pay for your education. You won't ever have the capacity, in my mind, in the Northern Territories to expand your programs that much because of various reasons. But it really needs you to partner with those in the South to make sure that others are overproducing, so that some of those will come to you of their own free will or through targeted kind of interventions. Like I mentioned, it really does need an all-of-country approach to make sure that we're producing, because if everyone's in their little silo, if Ontario says we only need 500 nurses a year and they're only producing 500, you're never going to benefit. You're never going to have enough in the Northern Territories. So it does require for some to overproduce, because we know there's movement across the country as well. But also it could be targeted overproduction, with agreements and purposeful recruitment.
Thank you, Ms. Little. Mr. Tester?
Thank you, Ms. Little. That was a very good response. And we're going to solve a national, I think to solve a national problem, we need national solutions as well. But it's that local level that we need to address as well, because we can't necessarily wait for all the other provinces and territories to come online. Do you think there would be value in tackling this first from a pan-territorial approach and find ways that each of the three territories who have similar operating environments for their healthcare systems to come together, and then, as a good starting point, and then find other partners from that area? I'm just trying to see how we could, start that coordinated approach between different jurisdictions, so we're not siloing the problem further. Thank you.
Yeah, I think it has to happen at all levels. As you said, within your own territory first, what are you doing that you can do, right? And I'll come back to that in one second with an example. But I do think perhaps engagement, across the territories, because it's easier to go down, and I'll say, I'm using quotes, to the south provinces with the three of you saying, this is our collective issue and we need your support, as to one of you going on your own. It's always easier to go in a group, as we know, and build your case, right? A stronger case. So I do think that's a great opportunity. Even if you look at your own territory and you look at, for example, so say you need, I don't know, say you need 50 nurses, okay? And you've currently got, 100 in the system. If you look at what those nurses are doing and go back to what I was saying about take away from them the things that don't require nursing education, paperwork, looking for supplies, checking machinery, faxing things, hire more local staff, support staff, I'm going to say, to take away some of those non-nursing functions in health centers and in communities. Then suddenly you have freed up 30% of your people's time so that they can actually see more clients. And so you need 30% less of them. So as opposed to needing another 50, you may be down to only needing now X number, because you have those nurses or more available that you could actually free up an entire nurse and say, okay, now we have another one to fill the gap where there was a vacancy there. So there are ways that you're going to have to look at how do you maximize the workforce that you have. In a global shortage, there is, dare I say, never going to be enough for everyone, right? So how do you take what you have and maximize and optimize the service level that they can bring and what they can do, and augmenting with other types of providers, that are supportive to them in those manners, like clerks and, admin staff and whatever. And then say, okay, we've done all that we can do. Now we still need X number, right? But I think those are ways. And like I said, looking at job shares is a way to fill things that it's maybe a little bit more work administratively, but it seems to be very appealing to people these days who are burnt out. People don't want to work full time anymore after COVID. Let's be honest. The burnout rates, as I said, are massive. And it's a way to keep people in the system. It may not be your preferred way, but as opposed to them leaving the healthcare system altogether or leaving your employment altogether, it gives you, some. And I think there's got to be a mix of those where you've got indeterminate full-time staff, you've got job shares, you've got part-time. It's a reality that those are what the workforce is demanding, unfortunately. Because of, the last couple of years of it's been culminating, I think, but the last couple of years when COVID happened just brought it to a head.
Thank you, Ms. Little. Mr. Tester, do you have follow-up?
Nothing further. Thank you, Madam Chair.
Thank you. Thank you for that. Mr. Hawkins, do you have a question?
Thanks, Madam Chair. Hi. Hey.
Okay.
Thanks, Madam Chair. Just ever so briefly, you did talk about engagement with nurses, and I'm very happy to hear that. I think building on other committee members' questions is very important in the sense that they recognize this particular issue. I often hear about the right type of engagement. Maybe if you could, for illustration purposes, set up sort of maybe a bigger picture sense of how you would view these engagement forums not only being created but used in a positive way, because often I hear not just the nursing, but whether it's the doctors or other types of areas that they have tons of ideas that could help, and let's be fair and honest, I suspect there's not one solution to cure them all, but these incremental solutions and ideas create positive synergies, and I'll just create a silly example. Well, let's buy Band-Aids by bulk as opposed to one at a time. We save 80% of the costs. And someone will go, oh my goodness, that's crazy. How did we not see that before? And trying to create an idea that fosters that type of synergy. And people feel valued. And, it creates the harmony of pride in one's work, thinking that their ideas mean something and of value. Because, after a while, you kind of get tired, yelling in an echo chamber that you don't hear anything back other than your own voice. And hence, at that point, you just kind of wonder why. And So how would you see, in essence, and I just provided a simple anecdote. I mean, I'm not suggesting how would we buy Band-Aids, but I think you understand the concept and the principle of what I'm really getting at is that we have really good ideas out there and we want to be able to connect people to actions. And how would you view this? Maybe I'll leave it open-ended for you and because I want meaningful suggestions appreciated and I want meaningful valued suggestions come into action. And then I think out of that we get some excitement amongst everyone. Thank you.
Thank you, Mr.
Great
Hawkins.
question.
Ms. Little?
I'm sorry, I keep stepping over you. I apologize. It's a great question. I think, first of all, and you hit on this in the last part of your question, it has to be engagement, not just consultation. So there's no point in going out and asking your healthcare workers what their ideas are if you have no intention of ever implementing any of them, right? Because the minute you go out and ask them for their ideas and do nothing with it or don't get back to them, you have lowered your credibility. You have, said to them, I don't value what you have to say. I was just asking you for the purposes of asking to say, tick, we did that. So it has to be really meaningful engagement. And I think there's many ways to do that. I've done some of this myself in my career as a consultant. Focus groups where I went into communities and I met with all the staff and said, tell me what's working well and what's not working well, and what are your ideas on how to fix it. They got a million ideas, and then it becomes a prioritization exercise. You look at a bit of a matrix that says, okay, which ones are the lowest, the easiest to do with the biggest impact, and that's where you start. So you might do that kind of an exercise, and you might do that multidisciplinary, you might do that within disciplines, and then you would get a big list, and then you need to go back to people then. This is a multi-phased approach. You don't just go out to them once. You have to validate with them after, say, this is what I heard you say. This is what you prioritize would be the biggest difference in your work life, or we've said it's the biggest difference from an economic perspective or whatever that is. And it's not that hard to do. We now have from everybody all across the territory and all the, focus groups we've done. And they can be online. I've done them online too. But people appreciate you coming in and sitting down and talking with them. And you get more, I think, not everyone's fit for Zoom. Some of us are on it all day long, but not everyone's fit for that. And so then you say, look, we've done our consultations. You tell everyone we've now got, 200 ideas. And then you put people through and ask them to prioritize them, right? And maybe you separate them out into different areas, the ones that are going to bring economic value, the ones that are going to impact the health worker, or the ones that are going to improve access to care, whatever they kind of categorize in. And then you ask people to prioritize within those buckets. And it's important that you probably choose some things from each of the different buckets. If everything you do is about saving money and makes things worse for the healthcare worker or the client or whatever, those aren't going to be popular with people. So making sure that you do something that's for the healthcare worker, something that's for maybe the cost, something that's for the system as a whole, whether it's accessibility or wait times reduction, and something that really improves the health of the population, I think is important. But it needs to be a multi-phased process. And I think you have to then take those suggestions and say, okay, maybe our staff then analyze them and say, what is the potential of this? It could save us this amount of money or that amount of money. It's important that that information is brought back to them to say, we took what you suggested, we did a bit of research on it, figured out what it could look like, and then bring it back to them to say, okay, now, we got everybody's ideas. We can't do it all. Where do people prioritize? And then come back and say, these are the ones we're going to do. Some organizations have actually provided, I'll call it an innovation fund. So some employers will say, you know what? And I know you're like health centers and communities in the hospital, but you might say to them, you know what? We'll give $1,000 or whatever it is available. People can apply for to say, there's a contest for your best idea of how to improve on this aspect or that aspect, thinking about the quadruple A maybe or something. And you have a little committee comprised of them, some of them, and you say those communities or those teams that came up with the best idea as voted by whatever or get chosen are going to get this little bonus, or they all get a free lunch. Food is, popular, but not sometimes. Or they all get their registration, their professional registration paid for. You have to find something that's meaningful to them. But sometimes a little competition and ideas can really spur some great ideas.
Little
That's my
Mr.
thoughts.
Hawkins?
Oh, thank you. I mean, I could find, clever ways of coming back with a different question to try to get the same end. I mean, I'm trying to get people excited again. And if we want different results, we got to find a different way of doing things. And that's all. And I mean, really, your thoughts have been most helpful. So why don't I leave it at that and say I appreciate your time and your insights, and hopefully, I'm sure we have million subscribers on our online channel, especially from the Department of Health, and I have no doubt they're following this very carefully. Which, at the end of the day, I really hope that they can find ways to stir the passion of nursing and certainly stir the passion of administration to find ways to bridge the two conversations. Thank you.
Mr. Hawkins, Mr. Nersu?
Yes, one concern about retaining nurses in remote areas such as the Northwest Territories. Have you encountered any solutions or ideas that would work within our jurisdiction? Thank you.
Yeah, so of course there are some unique to kind of rural, remote kind of jurisdictions like yourself, more northern. But I would say that across the board, almost the same retention strategies work no matter where you are. Nurses want to feel valued. They want to feel respected. They want to have a voice at the table. They want safe working environments. They want, zero policies on zero tolerance of violence, which is a huge issue they're combating these days in the healthcare setting. They want to have input on the decisions that are made about the work that they do and how the system functions. They need mental health supports, there's no doubt. And sometimes people in rural, remote need it even more because there's additional elements of isolation. You don't necessarily have all the resources in the community you might like to go and tap into. One of the things that came out, is and we've seen is, just the whole self-care notion and what you can do to provide to nurses to help them, whether that's physical activity, whether that's, yoga classes or things like that. It's a huge piece because they can't just go to the class, in downtown Toronto. There's not those kinds of things. So how do you support them with what you have in rural communities or offer them things? They all can't get out for continuing professional development. So how do you support them and bring that in to them, right? Which is somewhat unique to northern communities sometimes. So I don't think that being northern makes you, or remote makes you any, different than every other kind of retention strategy. There are some unique, maybe minor things, but I think that's probably 20% of the issues as opposed to the other 80, which are common across everyone in terms of what nurses are looking for and want for retention. Flexible employment is one, right? It's a little bit different when you're casual in downtown Toronto, where you can work this day and that day. In the north, you got to fly up if you're coming from the south. So that's why that other kind of job share, fly in, fly out model is maybe appealing, or opportunities where nurses can do telehealth. Some nurses, maybe you have ways that they can support your system from working from afar. I mean, that emerged so much during COVID, right? Where we couldn't fly people in because we didn't want to move people into COVID settings or et cetera. So I think those are other opportunities to embrace that are very appealing to people, and maybe where there's limited housing and things for them.
Thank you, Ms. Little. Mr. Nersu, do you have a follow-up?
Or a comment and anything, stating that these nurses need to feel valued and being given the opportunity to make decisions and being recognized, given their input in what could work within our smaller communities. Because right now most of our health centers are on are just open for emergencies only because there are lack of nurses. So, we're going to give the department, give them the opportunity to give these nurses more decision-making powers. So I believe they're the ones that know what's going to work and what's not going to work within these smaller communities within our jurisdiction. Thank you. Thank you for your presentation.
Thank you, Ms. Little. Would you like to respond to that?
Yeah, just one more thing I was going to add. Lots of places have done refer a friend. So you might think about a policy such as that, where nurses maybe can, if they can get a friend to come and work, they get a bonus for doing that, right? Lots of organizations, not just healthcare, do that, and it can be effective. So, sometimes look to the nurses to help you with some of those recruitment challenges, right, or retention challenges. But talking with them and finding out what makes them stay. Why did they come here? And talking to their friends. Why won't their friends come? What's it going to take to get them to come? Unfortunately, when you have a labor shortage, like in healthcare right now, and I'm going to say this, and it might not be the right way, but the power rests with the healthcare worker. They can choose where they want to go. There's a million jobs across the country. So, they're looking for financial gain. A lot of young people are looking to make good money and have a great adventure and not stay for a long time. So you got to make sure your salaries, your wages are competitive with other people as well, because that's a huge piece of what people are also looking for, right? In terms of a lot of people maybe come to the north to work for a couple of years, and make enough money that maybe they can then retire right at the end. But again, as I say, the reasons of why people come and stay are different based on the generations. So you really need to understand the differences in the generations, and there's lots of literature on that about what they're looking for. The new ones want, digital everything. They want the latest technology. They want this. They want to use telehealth. They want things at their fingertips. The older nurses, like myself, don't necessarily want that all the time. We weren't raised in that environment. We're embracing it, but what people want are different, and how they work depending on the generation.
Thank you, Ms. Little. I have my question is on cultural sensitivity. Like, what's your thoughts on that when coming into small remote communities or more northern communities? Thank you.
Yeah, great question. I think you have to make that part of your orientation, that any nurse that comes in has to have the basic cultural sensitivity training. Maybe you have a module. A lot of people, use the BC one, and I'm not going to pronounce it right. This Soyoyas or something like that. Sanayas. There's some established out there. I mean, they might not be a perfect fit for your context. You might want to create your own. Maybe you have already. But I think you need to make sure that every nurse has that training in hand as part of a requirement for their orientation when they start, whether they're full-time, part-time, or casual or job share, it doesn't matter. And I think, maybe there's even, a bit of a booklet you can create, right? That helps them understand some of the nuances in the culture within your territory. Not everyone learns the same way. Some people are readers, some people are visual, auditory, whatever. But I do think I understand it's necessary and a requirement that you should make them have that before they come in, or when they get there as part of their orientation.
Thank you for that question. The other one is, I'm not sure how to say it, but to ensure that nurses get involved in the community that they serve, that they work in. So having, it's more of a comment, but getting them involved in the communities. I know in some of the smaller remote communities, some nurses don't want to leave. They get there because they feel so valued and so a part of the community. Some people in the communities actually adopt them into their families. And when they have ceremonies, weddings, traditional ceremonies, the nurses jump right in there and just participate with the people. So people really encourage people to do that. So that could be part of their orientation things. It's more of a comment. Thank you. You can respond to it if you want.
Thank you. Yeah, I think that was back to the comment I was making about when you recruit people, you need to not only look at their professional integration and what they need to do in their job, but the social integration, the cultural integration is really important. So I totally agree with you. You know, inviting them that first week out to, be on the land or into a community dinner or whatever other cultural events, introducing them to people around town, telling them where everybody goes to get coffee on your day off kind of thing is really important part of their integration and helps promote their long-term retention. It can be a challenge for some, let's be honest, when you're in a small community and and you work at the clinic, you want some of your own time as well, to yourself. Because when you go to the grocery store, when you go here, everyone's asking you questions. Well, I've got this health condition. Like you're on 24/7 almost, right? And that's hard for some people that they don't want to then spend all of their time with the community after. They want some of their own time. So I do think we need to find a balance and a bit of respect for that to understand how they're feeling, because most other people go to work, finish their job, and they're done, right? But in this case, when you're in the community and it's a small community, they know you're the nurse, and they ask you all these questions about their health on their, in the evening or on your days off, which sometimes it's hard to get that work-life balance, right? So I totally support the social integration, but I just think we also have to acknowledge when some people want, or nurses or whoever, want their own time as well and don't necessarily want to fully do that because they may need personally a better boundary between, work and life or their own personal. So I think it can be encouraged and supported, but if people push back, I think you have to respect that too.
Thank you. Thank you for your response for that. Makes sense. It makes a whole lot of sense. Now I'm going to ask the committee members. We can do a second round of questioning. Does anybody have any further questions? All right. Hearing none, Ms. Little, I want to thank you for Ms. Morgan.
Thank you, Madam Chair, for allowing me one more question here. Ms. Little, you've spoken a lot about retention, and the phrase that really stuck with me was that the best recruitment strategy is an effective retention strategy. And I think that really hits home. I've heard that from lots of other healthcare practitioners around here. How do we measure whether or not we have an effective retention strategy? Given that, like you're saying, there are people, especially from younger generations, who we can really only expect to maybe stay in a job for a couple years, and you're saying that's sort of normal, we have to plan for that. Are there sort of universal measures or markers that, how do we know we're doing a good job with retention? Or, I suppose you have to match it with what you expect to achieve in terms of retention, but how do we set realistic goals and targets for ourselves and then hold ourselves accountable to effective retention? Thank you.
Morgan, Ms. Little?
Yeah, good question. So I think, again, tied to kind of whatever recruitment or retention strategy you have and some of your, initiatives and actions in there, you want to assign with that some sort of evaluation, right? As you say, to hold accountable and to know whether the initiatives and things you're doing are making a difference or not. So obviously turnover rate is an international one that everybody kind of measures, right? And you're right, because there are, to say that we're going to have a really high or a very low turnover rate, say 10% is not reasonable anymore. But I think you also want to look at, you might want to break that turnover rate down to say, okay, if you look at it by age, even by generations, to say, okay, are we getting somewhere where, yes, we may have a high turnover rate every 3 years for certain groups, but we've got other groups that are a much longer turnover rate, right? If everybody is doing a very low turnover rate and churning every 2 to 3 years, that's not what you want. You do need a mix of, the people who are going to stay for a lifetime, the people maybe going to give you 10, 15 years, and the people who are going to come in and go. Some of the other indicators you can use to evaluate is even like a 1-year retention rate. So if I hire someone and you're tracking all the people you hired within 1 year, are they still employed in the Northwest Territories? Are they still employed at 2 years as a retention rate? Because that will tell you a lot whether you have brought in the right people. If they came in and they're gone in 6 months, this wasn't the right job for them or the right environment. And so that screening process of how you're interviewing people and making sure they understand the context of the Northwest Territories and life here and the healthcare system is right. Because if they came and they left, and there's no, reason that there was, something with their family afar, they probably experienced some culture shock and what they experienced was not what they expected. And so there's a disconnect there. And so that drives what you might do and look at what you're telling people when you hire them and interview them and your recruitment efforts, right? If they're staying for 2 years or 3 years, okay, that's great. But like I say, I think you have to expect some level of turnover. And lots of people are now saying, anywhere from 25 to 35% turnover is going to be realistic now, especially when you're in rural and remote areas. Your turnover rate's going to be higher than in the South because of the pure nature of not everyone wants to come and stay in that kind of environment. But if you can get a couple of years out of them, it's a couple of years of someone versus no one, right? So I think there are measures like that that you can look at. Other things around, staff satisfaction surveys, asking them how they're happy with things or how they're happy with this aspect or their work environment or their involvement of decision making. Doing some of those surveys on a regular basis is another important piece, and it shows to them that you care and you're reaching out to find what they think as opposed to just statistics. So those would be my suggestion.
Miss Little, Miss Morgan? No. Anybody else? Mr. Testart, do you have another?
No, thank you.
Okay. All right. Mr. Nersu.
Oh, good, thank you.
Okay. With that, thank you very much for your joining us today, Ms. Little. We appreciate your presentation. This concludes today's public briefing on healthcare sustainability and accountability. The public proceedings have now concluded. Thank you.
Thank you very much.
Okay.
Bye.